So today we are going to talk about the evaluation of abdominal conditions by acute abdominal conditions by computed tomography. First, what is acute abdomen? Acute abdomen is defined as a clinical syndrome characterized by sudden onset of severe abdominal pain requiring emergency and medical or surgical treatment. A small number of conditions is responsible for about 56% of the cases of acute abdomen. So that's the part that we should know and we should diagnose confidently, because we will diagnose more than half of the cases of acute abdomen. The most frequent being acute appendicitis, acute cholecystitis, and small bowel obstruction. In about 1/3 of the patients, even after surgery, no diagnosis could be reached. Imaging findings or procedure details. Acute pain can be classified according to its topographic location into right upper quadrant, left upper quadrant, left lower quadrant, right lower quadrant, epigastric, generalized, and flank pain. So let's start with the right upper quadrant. What are the most common causes of right upper quadrant pain? These are mostly it's acute cholecystitis, other causes including biliary colic, perforated duodenal ulcer, omental infarction, retrocecal appendicitis, right-sided diverticulitis, liver abscess, ruptured hepatic neoplasm, and hepatic vascular disease. These are from the most common to the least common. So the most common cause of right upper quadrant pain is acute cholecystitis. CT findings of acute cholecystitis, I think everyone knows it. It's wall thickening of the gallbladder, more than 3 mm, distended gallbladder, pericholecystic fluid, haziness of pericholecystic fat, increased attenuation of the bile, intramural or intraluminal gas in cases of emphysematous cholecystitis. It might be complicated by perforation resulting in pericholecystic abscess formation. For example, you can see here, this is a CT scan of the upper abdomen showing thickening of the gallbladder wall associated with pericholecystic fluid collection indicating acute cholecystitis. Also you can see it here, and you can see here obviously there is gas within the wall of the gallbladder indicating emphysematous cholecystitis. Again here you can see some fluid collected here indicating perforated gallbladder with pericholecystic fluid formation, which might be an abscess or a bilioma. Again here you can see this, the site of the perforation and the leak of the bile. Here you can see there is a complex cystic fluid collection with enhancing wall, enhancing septum indicating pericholecystic abscess formation. This is abscess. Again, the same thing here. Several other conditions might cause acute pain in the right upper quadrant, including, for example here, biliary colic. You can see this is a stone in the, this is without contrast, the CT scan is without contrast. You can see a stone in the distal or in the duodenal aspect of the common bile duct, causing biliary obstruction resulting in biliary colic. And you can see when the contrast is administered, there is a edema surrounding the common bile duct, and the stone is markedly less visible in contrasted images. So that's why you should be careful to have pre and post contrast images. You can see here, this is a case of Budd-Chiari syndrome. The liver is markedly enlarged. It shows heterogeneous post-contrast enhancement, sparing the caudate lobe, typical, associated with ascites, which is also typical, and the hepatic veins are clearly not visualized in this case due to thrombosis resulting in Budd-Chiari syndrome. This is a case of abscess formation. You can see here is a multinodular fluid collection in the right liver lobe. Okay, it's liver abscess. You can see here another case of fluid collection with air fluid level, and some you can see here there is a free intra-abdominal fluid, another case free intra-abdominal fluid with evidence of perforated ulcer resulting in free intraperitoneal air. These are different causes of right upper quadrant pain. So, left upper quadrant pain, most common causes are splenic infarction, splenic abscess, gastritis, gastric ulcer, and acute pancreatitis. You can see that this is a CT scan of the abdomen. There are areas of heterogeneous hypo enhancement in the spleen. This is a wedge-shaped area. This is also a little bit of a wedge shape, indicating splenic infarctions. This is a case of hematological disorder. You can see the splenomegaly. Okay, and this is a case of acute pancreatitis affecting mainly the tail of the pancreas. You can see here there's a fluid collection near the pancreatic tail, between the pancreatic tail and the hilum of the pancreas. Again, you can see it here, and the pancreas appear congested and swollen and edematous. It's typical of pancreatitis. Cause of left lower quadrant pain, the most common cause is acute diverticulitis. Other causes including obstructing sigmoid neoplasm, epiploic appendicitis, gynecological diseases, and acute urinary colic. The most important cause of acute lower quadrant pain is acute diverticulitis, which manifests as pericolic fat strangling in 98% of the cases, segmental colonic wall thickening more than 4 mm, pericolonic fluid, engorgement of the mesenteric vessels. The complications include walled-off perforation, intraperitoneal perforation, abscess formation, fistula formation, and bowel obstruction in about 12% of the cases. So, you can see here there is a stranding of the perisigmoid fat planes. You can see there are some diverticuli here and there. The stranding of the fat planes indicates diverticulitis. However, there is no signs of perforation. Again, you can see here strangling of the fat planes, some engorgement of the mesenteric vessels, and again the same thing here. You can see here there is a collection formation, thickening of the wall of the sigmoid, definitely more than 4 mm thick, with a fluid accumulation indicating walled-off abscess formation. CT has a high sensitivity, specificity, and accuracy in the diagnosis of acute diverticulitis, being also highly sensitive in the detection of extracolonic complications. This is another cause of left lower quadrant pain, which is a gynecological disease. Okay, there is a collection with a fluid debris or fluid debris level, indicating blood or hemorrhage within the cyst. This is a hemorrhagic cyst in the left ovary or left adnexia in general. Okay, now causes of right lower quadrant pain, the most common is acute appendicitis. Other causes including Crohn's disease, acute typhlitis, cecal diverticulitis, Meckel's diverticulitis, mesenteric adenitis or mental infarction, epiploic appendicitis, ruptured cecal neoplasm, gynecological disease, and acute urinary colic. The most common cause is acute appendicitis. The CT will show fluid-filled enlarged appendix, focal cecal apical thickening, periappendiceal fat strangling, calcified appendicolith, and sometimes you can see it, appendiceal wall enhancement, periappendiceal fluid perforation resulting in phlegmon formation and abscess formation. So, what we can see here, there are different cases of acute appendicitis in different stages. For example, here you can see this appendix is thick, fluid-filled, associated with strangling of the surrounding fat planes. You can see here there is a calcified appendicolith within the thick, inflamed appendix. Okay, again you can see here strangling of the surrounding fat planes and thick wall appendix. Again you can see the appendicolith within the appendix, resulting in thickening of the wall and enhancement. And you can see here cecal wall thickening. Sometimes you will not see the appendix directly, but you see the thickening of the cecal wall due to inflammation. Again, here and there. This is a case of complicated acute appendicitis with rupture of the appendix resulting in fluid collection, abscess formation containing some gases, and you can see the appendicolith floating within the fluid collection. Acute appendicitis may be efficiently detected by CT, which has a high sensitivity, specificity, and accuracy. Non-visualization of the appendix on the CT virtually excludes acute appendicitis. If you don't see it, it's not there in CT scan. As a consequence, this method may contribute to decrease the rate of negative laparotomies in patients with right lower quadrant pain. So, acute appendicitis can be a very good indication for a CT of the abdomen. Even you can do it without contrast. you'll still see the strengthening, the thickening, the perforation, the appendicolith. All of these complications can be seen without contrast. So, other disorders might cause acute pain in the right lower quadrant, including this is a thick-walled ileal loop with a mucosal enhancement, indicating a Crohn's disease. You can see the thick-walled enhancing small bowel loops here and here, and you can notice there is a skip lesion characteristic of Crohn's disease. Again here, also you can see the comp sign, the mesenteric vessels are engorged, and here you can see a sinus tract formation containing a small air bubble. All of these are criteria and characteristics of Crohn's disease. Cecal diverticulitis, you can see it here, cecal wall thickening and digestive fast strengthening in patients with diverticulitis. You can see the fast strengthening here and here, and you can see there is a diverticulum which is impacted, okay, resulting in cecal diverticulitis, which is not as common as sigmoid diverticulitis. It's relatively rare, but we should keep it in mind. Epiploic appendicitis is a common cause of abdominal pain that is usually neglected or we're not paying enough attention to it. You can see there is the epiploic appendages are characteristic by peripheral soft tissue density and central fat density, okay, associated with surrounding of the adjacent fat planes. When there is some sort of torsion of the appendage, resulting in epiploic appendicitis. Most of the times it will go on undiagnosed or neglected. This is a common cause of lower abdominal pain. It's a mesenteric lymphadenitis. You can see here there are several mesenteric lymph nodes. However, there is nothing else. The appendix looks normal. The small surrounding bowel looks normal. So it's just a case of mesenteric lymphadenitis. It might be misdiagnosed as appendicitis, and the patients will go to laparotomy and will be negative laparotomy. You can see here there is a gynecological abnormality which includes a large uterine fibroid, large uterine fibroid with areas of central necrosis indicating degeneration, and there is another smaller fibroid with peripheral calcification, so it might be also a cause of lower abdominal pain. Acute generalized abdominal pain, there are three main conditions that are most common, including bowel obstruction, ischemic bowel disease, and gastrointestinal perforation. Other causes including gastroenterocolitis, inflammatory bowel disease, and intra-abdominal sepsis. CT may be requested to differentiate functional obstruction, yani paralytic ileus, from one with underlying mechanical cause, mechanical ileus. Causes of paralytic ileus are generally related to post-operative states or secondary to ischemic conditions, inflammatory or infectious disease, metabolic, hormonal abnormalities, drugs, innervation defects, and no organic lesion found in these patients. So paralytic ileus is small bowel obstruction. Generally speaking, there is no cause. You cannot see a cause by CT scan. The most frequent causes of small bowel obstruction are related to adhesions and hernias, Crohn's, and less commonly neoplasms. Rarely may be due to other causes. On the contrary, large bowel obstruction, carcinoma, diverticulitis are the most common implicated causes, whereas volvulus remains as uncommon entity. Yani, if you see large bowel obstruction, you should expect to find the cause. Diverticulitis, tumor, neoplasm. If you see small bowel obstruction, you relatively less likely to find the cause. The adhesions, you cannot see it. You see a point of transition, but you don't see the adhesion. Adhesions can be seen only by laparoscopy. That's it, nothing else. No, not by CT, not by MRI, not by X-ray, not by ultrasound, nothing. You can see here there is a large, prominent dilatation of the small bowel loops. It's air-filled with multiple air fluid levels here and there. It is due to spontaneous bacterial peritonitis. You cannot see a cause as a mass or anything else, but you can see here there is an enhancement of the peritoneum due to the bacterial peritonitis, resulting in paralytic ileus. It is not non-mechanical small bowel obstruction. Also, this is a non-mechanic, it's a small bowel obstruction caused by adhesions. We cannot see the adhesion itself. Adhesion bands cannot be seen by CT scan. However, you can see a point of sudden transition from dilated into normal caliber small bowel loops here and here, indicating when there is sudden point of transition, indicating an adhesion band at this part. So you should be careful to follow the small bowel slice by slice, cut by cut, till you see the point of transition. Okay, and you can see here this it's like small bowel feces sign. The small bowel looks like it's loaded with fecal material. There are multiple small air bubbles within the small bowel due to small bowel obstruction. Again, small bowel obstruction caused by a neoplasm. You can see there is a tumor here at the beginning, at the ascending colon, associated with a markedly dilated small bowel loops with multiple air fluid levels. So it is a mechanical obstruction, okay, but it's not due to tumor of the small bowel, it's tumor of the large bowel, okay. And here, well, this is a high-grade obstruction. What you can see here, there is a low-grade obstruction caused by an intussusception. There is a tumor of the small bowel, and you can see this is the intussuscipient and intussusceptum, bowel within bowel appearance, okay, resulting in a low-grade small bowel obstruction. Here you can see another cause of small bowel obstruction. It's a gallstone ileus. You can see the stone here within the small bowel loop, resulting in a relatively low-grade small bowel obstruction. And you can see there is an air fluid level within the gallbladder, and you can see there is a thickening of the duodenal wall, because this is the point of passing of the stone from the fundus of the gallbladder into the small bowel, okay. And you can see on the x-ray, this is an air fluid level within the gallbladder, indicating gallstone ileus. The diagnosis of bowel obstruction relies on the identification of transition zone from distended to decompressed bowel. In cases of malignant obstruction, the transition may be abrupt with irregular bowel wall thickening, sometimes associated with masses or lymphadenopathy. The diagnosis of adhesions, the most common cause of small bowel obstruction, it is a diagnosis of exclusion of the majority of cases. We cannot see adhesions by radiology modalities in general. The only way to diagnose adhesions is laparoscopy. Okay, we cannot diagnose it, we cannot see it. However, we can see a sudden point of transition from dilated to normal caliber bowel loops, which indicates that this is a site of obstruction. If you cannot see anything, then most commonly it's an adhesion, especially with a history of previous abdominal surgeries. CT has the ability to easily identify the site, severity, and cause of bowel obstruction, may detect complications such as ischemia. This is especially true in cases of high-grade obstruction, where CT possesses a high value, highly sensitive, highly specific, highly accurate. CT performs less well in patients with low-grade obstruction, in whom the accuracy may drop to approximately 50%. So, if you have a large, high-grade bowel obstruction, you should look for the cause, and most of the times you will find it. If you have low-grade obstruction, if you don't find the cause, that's okay, because the CT accuracy drops to 50% in low-grade small bowel obstruction. Some patients, the bowel obstruction may be a closed loop process. CT may demonstrate C or U-shaped bowel loop, whirl sign, which is a twisting of the mesenteric vessels, and strangulation. Strangulation, you can conclude that there is strangulation by finding a non-enhancement of the thick bowel wall, mesenteric edema and hemorrhage, engorgement of the mesenteric vessels, ascites. Also might diagnose infarction, which is diagnosed by gas in the bowel wall, mesenteric or portal veins. For example, here you can see there is a closed loop large bowel obstruction, there is a markedly dilated bowel loop with air fluid level, and you can see here there's the whirl sign, and by x-ray you can easily diagnose a case of sigmoid volvulus. This is a sigmoid volvulus, definitely, and by CT scan you can see there is the whirl sign here and the dilated sigmoid loop. Again, you can see here there is the fluid-filled, markedly dilated bowel loop and this is the point of transition. It's twisted. This part is twisted, okay? And the urinary bladder appears displaced. So again, here you can see twisting of the mesenteric vessels here and here, okay? And you can see the bowel wall is dilated, non-enhancing, surrounding of the fat planes, small amount of ascites. You can see here, this is an internal mesenteric hernia, strangulated, resulting in thick-walled, non-enhancing, dilated, stranded fat planes, indicating strangulation. Ischemic bowel disease may be a consequence of arterial occlusion, venous thrombosis, or non-occlusive ischemia, such as in cases of hypoperfusion. CT findings including filling defect in the mesenteric vessels, bowel dilatation, bowel wall thickening, and edema, diminished enhancement of the bowel wall, mesenteric edema and hemorrhage, free intraperitoneal fluid, intestinal nematosis, portal and mesenteric venous gas. You can see here there is a gas within the wall of the stomach, and you can see portal vein, gas within the branches of the portal vein here, and you can see the filling defect in the mesenteric artery, indicating bowel wall ischemia with portal venous gas, and طبعا of course ascites. The same thing you can see here, there is a filling defect in the portal vein. طبعا it can be filling defect in the artery or in the vein. In both cases result in infarction, venous infarction, arterial infarction, doesn't matter. Okay, so you can see a filling defect in the portal vein here. Okay, you can see a patent artery, it's enhancing. The bowel wall is thick, edematous, stranded fat planes, it's not enhancing. Okay, there's ascites, marked ascites, indicating bowel ischemia. Again, you can see there ischemic bowel disease. There is a gas in the portal vein and in the bowel wall associated with ascites, and this is the gas in the main portal vein. By the way, portal vein gas is a very poor prognostic sign. It's about, I think, 90 to 95% will result in mortality. Portal vein gas, especially in adults. GI perforation may be a result of peptic ulcer, necrotic neoplasms, ischemic or ulcerative colitis, diverticulitis, and increasingly endoscopic instrumentation, resulting in pneumoperitoneum, focal fluid collection, extravasation of oral contrast, and local inflammatory changes in the bowel wall, adjacent fat, and mesentery. For example, you can see here there is a perforation of the duodenum, resulting in fluid collection in the anterior perirenal space with some stranding, pre-renal space, with stranding of the adjacent fat planes, and by endoscopy you can see a necrotic ulcer. Again, you can see here there is evidence of free air, intraperitoneal air here and there, and you can see there is evidence of fluid collection with perforation of the duodenal, perforated gastric neoplasm. Sorry, this is the thick tumor in the stomach with perforated malignant ulcer, let's say. Okay. Again, here you can see there is duodenal perforation secondary to endoscopic mucosectomy. There is an endoscopy procedure, and during the endoscopy resulted in perforation of the duodenal wall. You can see here by endoscopy this whitish thing is the cautery, the thermal snare cautery, and this is the perforation of the duodenal wall. And you can see there is a free air, intraperitoneal air here and there, and this is the site of the perforation. Again, in the lung window, you can easily appreciate the free intraperitoneal air and air within the bowel wall. CT can detect pneumoperitoneum, which is overlooked on conventional radiography. Nevertheless, the precise size of perforation may be difficult to determine because the location of free air does not correspond with the site of the perforation. It's not always where you see free air, this is the site of perforation. However, if you give oral contrast, the site of the contrast leak corresponds to the site of the perforation. So you can see here there is additional condition causing generalized acute pain, which are relatively rare. example, this is a case of pseudomembranous colitis. You can see there is a thick wall of the bowel, thickening of the hostile folds, also abundant amount of free intra-abdominal, intraperitoneal fluid collection. This was a case of pseudomembranous colitis. Epigastric pain, most common cause is acute pancreatitis, leaking aortic aneurysm and aortic dissection. Should keep it in mind. The findings of the acute pancreatitis, if it is mild, it might be overlooked by CT scan. However, the more severe cases, there will be gland enlargement, parenchymal necrotic areas, peripancreatic exudates, and the fluid collections in the lesser sac, anterior pararenal space, mesenteric root and transverse mesocolon, and might be complicated by pseudoaneurysm formation, thrombosis, and abscesses. For example, you can see here these are different cases of acute pancreatitis. You can see there is necrotic, swollen, non-enhancing tail of the body and tail of the pancreas, and you can see here fluid collection, and you can see again peripancreatic fluid collection, and another case of strengthening of the mesenteric fat planes. You can see here there is a complication. These are complications of acute pancreatitis, including false aneurysm of the gastroduodenal artery here with thrombosis, okay, and this is a regional abscess formation in the pancreatic tail with containing gases. Yani abscess contains gas and fluid, okay, so you should keep it in mind. It's not abscess fluid. Abscess contains gas and fluid. Several studies have determined that the CT correlates with the clinical severity of the acute pancreatitis, and the degree of parenchymal necrosis predicts the patient outcome. As a result, the CT is the modality of choice for staging the extent of the disease and for detecting complications. And again, if you don't see the pancreatitis on the CT scan, this indicates a case of mild acute pancreatitis. So the severity and the outcome of the acute pancreatitis can be determined by CT scan. Clinical mimickers that can attribute to acute looks like acute pancreatitis is a case of, for example, aortic dissection. This is a complicated case of aortic dissection extending to the superior mesenteric artery. You can see this is the intimal fold of the aorta and extends into the superior mesenteric artery. Celiac and superior mesenteric, you can see it both. This is the celiac trunk and this is the superior mesenteric artery. Flank pain, most common, is due to urinary colic. Other causes including pyelonephritis, ruptured renal neoplasm, renal vascular disease, appendicitis, diverticulitis, and small bowel obstruction. The urinary colic is definitely the most frequent. You can look for radioapic stones at the uretero-pelvic or uterovesical junction, periurethral fast stranding, hydronephrosis, perinephric stranding, and renal enlargement. For example, this is a very common cause. You can see there is a hydronephrosis, hydroureteronephrosis here. The ureter is prominent, and when you follow it up, you can see a stone at the uretero-vesical junction. CT is more accurate than conventional radiography or ultrasound in detecting the urinary stones, but care should be taken to obtain non-enhanced and in post-contrast enhancement, because the IV contrast might hide the stone, especially in the delayed phase. The contrast will cover the stone. Various other disorders may be responsible for acute flank pain, including acute pyelonephritis, emphysematous pyelonephritis. For example, you can see here these are gas collection in the perinephric space, indicating emphysematous pyelonephritis, and you can see gas collection within the renal collecting system with surrounding of the surrounding fat planes, or the case of acute pyelonephritis and emphysematous pyelonephritis. These are cases of acute renal vascular disorder. This is a case of renal transplant, and you can see there's the renal vein is thrombosed and non-enhancing, indicating venous thrombosis in a transplanted kidney. Okay, nowadays we are seeing cases of renal transplant commonly in our area. Also, you can see here there's a thrombus within the renal artery, resulting in non-enhancement of the left kidney. There's no, compare the right and the left kidney is non-enhancing due to arterial thrombosis. So in conclusion, CT is being increasingly seen as the first-line imaging method in the study of patients presenting with acute abdominal pain, since it lacks the disadvantage of plain films and ultrasound, and it's able to replace them in a wide spectrum of situations with its cost-effective, highly accurate imaging modality in the majority of acute abdominal conditions. The topographic classification of pain by quadrants may facilitate the answer to a specific question. So if you have a right upper quadrant different from the left upper quadrant, and so on and so forth, as we explained previously. And this method has the potential to positively affect the outcome of patients and has gained status of gold standard for the non-invasive evaluation of acute abdomen over the last few years, particularly often after the development of multi-detector CT scan. Thank you very much. So, any questions?
Just last slide, you said lacks the disadvantage of ultrasound.
Yes. CT lacks the disadvantage of ultrasound and plain abdomen because you have first the multi-slice capabilities. You have the reconstruction and the MIP and other capabilities. You have the oral contrast, the IV contrast. You can see a wide variety of abnormalities in CT that cannot be seen by ultrasound or plain abdominal X-ray. For example, in cases of acute pancreatitis, most of the times you will see nothing by plain abdominal X-ray, and even by ultrasound, if it is severe, you might see some sort of fluid collection or abscess, but in mild to moderate cases, you will see nothing by ultrasound. Okay, it's fast, it's non-invasive, and in cases of acute abdomen, of course, there is a very clear indication for CT scan. You cannot see there is radiation exposure while ultrasound doesn't have radiation exposure. We are talking about acute abdomen. The cost benefit is clearly in favor of CT scan. So every radiologist and every surgeon should have a very good understanding of the most common findings in CT of the acute abdomen, because clearly we might need it like on daily basis. It's not a rare, every day we see cases of acute abdomen, different kinds. Okay, any other questions?
Regarding this, the picture was almost the same with the appendicitis.
Yeah.
We give differentials, or
If you see a normal appendix, then you go for cecal diverticulitis, because normal appendix on CT scan excludes appendicitis. If you don't see the appendix, or if it's inflamed with the cecum, then you might give a differential diagnosis. Okay? Anything else?